Back in May of 2020, estimating the actual deaths related to COVID-19 was difficult. This was because of a rule issued by the National Center of Health Statistics stating that all deaths where COVID-19 has caused or is assumed to have caused or contributed to the death should be reported as a COVID-19 death. This is fine when a healthy 42-year-old nurse with no pre-existing conditions dies of respiratory failure after exposure to the disease, but more problematic when an 88-year-old who is on supplemental oxygen in a care facility develops a urinary tract infection, is taken to the hospital, and dies in the emergency room. He may be listed as a COVID-19 death, even though he may not have been tested, let alone tested positive. There have been many questions about the validity of death data during this pandemic. Rumors of misclassification of cause of death have been common, but there is a way to avoid this uncertainty and to estimate excess deaths for a time period without any debate over labels. This method was first used by John Graunt in the 17th century and is widely considered to be the beginning of epidemiology, the study of incidence, distribution, and control of diseases and other factors relating to health. Just like people today feel skeptical about the number of deaths attributed to COVID-19, Graunt was skeptical about the number of deaths attributed to the plague. Using the weekly mortality numbers recorded in the London Bills of Mortality, he calculated weekly average deaths in normal times, which he then subtracted from actual deaths in the plague years to come up with excess deaths. This approach to estimating the causal effect of an epidemic is sometimes called an excess death analysis, and it is easily applied to the COVID-19 numbers to give an estimate of the true death toll using data from the CDC. Think of the COVID-19 pandemic as a treatment. The treatment group is the US population from the 3 months between February 1st and April 30th, 2020. The goal is to measure the causal effect of the treatment on their lives. There needs to be a control group whose members are just like those in the treatment group, but not exposed to COVID-19. We used the US population for the same 3-month period during the years 2014 through 2018. The dependent variable is the total number of people who died. One of the characteristics of COVID that was obvious even in May was that it hit some age groups more seriously than others. So we used age groups to stratify the data. Table 1 shows the total number of deaths recorded for the control group from February 1st to April 30th, 2014 to 2018. On the right side are the parallel figures from 2020. Numbers for each year are not strictly comparable because 2016 and 2020 are leap years and contain an additional day. Calculating daily death count adjusts for this. Table 2 shows the total number of daily deaths in the US from February 1st until April 30th, 2014 to 2018, with the 2020 number on the right. This table also shows the mean number of daily deaths for each category. We could have used this as an estimate of what is usual and therefore what we would expect to see for 2020, but that would have missed the time trend of increasing deaths. Instead, we fit the data with an expanded model that had an age effect based on the mean deaths for each age group and a second term based on the regression of age-adjusted death rates against year. This approach accommodates yearly changes associated with population growth and aging. Table 3 shows the actual number of daily deaths in 2020 by age category and total, the estimate for what the deaths would be based on prior years, or fit from model, and the residual, which we can attribute to the net causal effect of the COVID-19 pandemic. Those under 25 had fewer deaths than what was expected, but those over 55 had in excess of 497 deaths, which is 6% of the total number of daily deaths in 2020 for February through April. This would be 44,730 excess deaths for those 55 and over for the 90-day period. The article this is based on was written back in May of 2020, 98 days after the first COVID death was recorded in the United States. Much has changed since then, but what has not is that in the constant reporting of rising numbers of deaths, there is never parallel information. Compared to what? This is how we can tell how the treatment is affecting the experimental group, by creating a control. The residuals column in Table 3 is the estimate of the causal effect of the treatment of being exposed to the pandemic in 2020, relative to the control of the years 2014 to 2018, when people were not exposed. What makes the treatment year different from the control year? The obvious answer is the pandemic. But for one of 3 months examined, many states in the US were under stay-at-home isolation orders, which may have reduced deaths from traffic accidents. The age group with the most daily traffic fatalities is drivers between ages of 45 to 54, and the daily traffic fatality rate for them is about 30. This could account for some of the negative residual we see in the age group in Table 3. Though this is a somewhat indirect measure of COVID-19's effects on fatalities in the US for the time period studied, it is free from the uncertainties of diagnosis that were seen in the early days of the pandemic, since they are total deaths and not based on any classification. A shortcoming of this study is that it was done so early on, with at least 45 and up to 60 of the 90 days examined showing no significant difference between the control group of 2014 to 2018 and the treatment group of 2020. This means what is presented is the effect of the pandemic being seen in April, averaged over a 3-month period. But it is still an example of how to assess the deadliness of the pandemic in a way that is not affected by idiosyncratic diagnoses.